Hello, I'm Denise Lockwood, owner of the Racine County Eye news website. Today we're talking about COVID-19, and I know you're probably all tired of hearing about this virus, but there's a very big reason why we're going to talk about it today. So I had a conversation with Dr. John Raymond, the president and CEO of the Medical College of Wisconsin, about the virus this week. He said that even though the number of new cases has decreased significantly, the city of Racine remains a hotspot, with the highest rate of infection per 100,000 residents in the state. And Dr. Raymond reminds the public that the virus is still very much with us and still spreading. So here's the conversation we had this week.
How are you, Dr. Raymond?
I'm doing well. I hope you are too.
I am, actually. It's been kind of a little bit of a roller coaster around here, I imagine, for you as well?
Well, it's unfortunate that public health issues become politicized, but I think that's just the way it goes.
Yeah, unfortunately. Tell me a little bit about, some of your main concerns as you look at what the dynamic is in Wisconsin, and if you've got any insight into what's going on in Racine, because Racine seems to be a pretty big hot spot as well.
Yeah, okay. I'll be glad to get started. Racine County has a little over 2,100 cases as of yesterday. So it is one of the areas of the state that has the highest burden of COVID-19. And the 1,078 cases per 100,000 residents exceeds Brown County, which, is one of the nationally publicized hotspots. They're at 1,009. And is second only to Milwaukee, and Milwaukee's had a higher number the last few days, so it's actually that place in the state that has the highest per capita at 1,090. And I know last week it was switched the other way around. So I think there are a number of factors that have contributed to Racine County's high per capita COVID-19 case rate. First I'll say it's on I-94 between Milwaukee and Chicago, and both of those cities had a fairly high burden of COVID-19. There's also a high percentage of essential workers in the Racine area from Hispanic and Latinx demographic. And as you know, across the country, Hispanic and Latinx, as well as young people, are probably the two largest growing demographics in terms of newly diagnosed COVID-19 cases. We've also had, like many other municipalities, outbreaks in congregate living situations, such as nursing homes and long-term care facilities. And you've also had outbreaks in essential business settings as well. And I would say that the conflicting messages that you've received from local leaders in the Racine area hasn't helped. I think people are confused about the right thing to do, and those mixed messages don't help. But as of today, Racine County is actually doing pretty well. Your daily deaths peaked in early June, and they've been dwindling down. You now have a cumulative 60 deaths. And Racine County cases peaked on May 18th, I think, with 83 cases. And you've seen a very steady decline in newly diagnosed COVID-19 cases since then. And during that period of time, your testing capacity has actually increased. So I think that's a real decline in the burden of COVID-19 in your region.
Yeah.
And the DHS website, which just was updated with the new feature yesterday, shows that although Racine County still has a high case burden, the trajectory of the pandemic has improved significantly week over week.
One of the things that I noticed about where we're testing, though, is over the last few weeks, we've been testing the prisons. There are 4 prisons in Racine County, and there are, I think, a few thousand people that are under their care. And so we've really kind of shifted that testing capacity towards more institutional type settings, it seems like. And over like the last week or two, we haven't tested. We've tested some, but I'm wondering like the breakout of like the institutional settings versus when we have community settings.
Yeah, to get the best information from Racine, you're probably going to need to talk to the local health departments.
Yeah.
Because the information on the DHS website is usually delayed by a day or two, and it isn't as complete as we'd like. But one thing that we can say for certain is most of the deaths, about 50% or more, in many of the areas that have been hard hit by COVID-19, have occurred in these congregate living situations, primarily nursing homes, rehab centers, and long-term care facilities. There's a high incidence of COVID-19 in prisons and correctional facilities as well. But because the population there tends to be younger, not as many deaths per capita. But just about half of the cases that have been documented in hotspots across the country are in these congregate living situations. So I think the local focus on doing testings in prisons and nursing homes makes a lot of sense.
Yeah. Well, I do know like some of the behavior of how we've responded has kind of changed. For example, like one of the policies that just changed, the prisons weren't accepting like prisoners from the jail setting, so they didn't have like more new people coming in. But now that's changed, and I know that like the judges, there's a lot of policy making on how we respond that seems to be kind of loosening things up a little bit. Do you guys have any concerns that this is too soon, or we're handling it well policy-wise?
Well, I could talk about policies that are more specific to the municipalities, the states, and the counties in general, rather than specific living situations. I think the loosening of some of the government restrictions has hurt us. And because the issue's become politicized, it's been difficult for people to get good information about what they can do to protect themselves. On the other hand, we do know a lot more about how to take care of patients with COVID-19, and we have a much larger testing capacity than we had even last month. So I think the fact that we're able to test people mitigates somewhat against some of the policies that have been loosened up. And we also know better who to focus on. So these would be at-risk populations like prisons, people that are in nursing homes, employees included. As well as some demographics. So people with risk factors such as obesity, high blood pressure, age over 60, we can focus our testing more carefully on those people. And we can also look at some of the demographics to focus our efforts on people in communities of color that have a disproportionate number of cases of COVID-19, and at least in terms of African Americans, have worse outcomes.
Why is that?
Well, we actually don't know the reason why, in particular, African Americans have worse outcomes. But I think it has more to do with a lot of the factors that contribute to overall health and not necessarily just COVID-19. So, for example, I think institutionalized racism would fall into the bucket of the social determinants of health, maybe not stable housing, not living wage jobs, not being able to live in a safe neighborhood, maybe living in smaller homes where it's more difficult to socially distance from somebody that might have been exposed. More essential workers. It's very, very difficult for people in these essential jobs to protect themselves with face coverings, especially if they have to interact with a lot of people in the communities that aren't wearing face masks.
So when you're looking at what's working in how we're responding, what are you seeing that is kind of the lessons along this path?
But I think early in the pandemic, the moves that municipalities and the state made to encourage people to stay at home were the right moves. So in particular here in Milwaukee, Mayor Barrett, there in Racine, Mayor Corey Mason, and Governor Evers with their safer at home orders, Really, I think that helped us to slow the spread early in the pandemic. Now that those government orders have been ruled unconstitutional, it really is, we're going to have to rely on individual behavior to do the right thing to try to slow the spread of COVID-19 down. And I know that people are suffering from lockdown fatigue. We're also suffering from what I would call an infodemic, which means that we've been inundated with too much information, much of which has been poorly curated and not subjected to critical analysis. And some of the press has sensationalized, oversimplified, and overinterpreted preliminary findings about COVID-19. I'd say we've also seen the rise of pseudoscience, self-proclaimed experts, opinion science, and narratives that have been cobbled together to support political positions that haven't helped us. So COVID-19 is not gone, and it's not going to be gone until we have an effective vaccine or an effective preventive medication. And as you mentioned early on in our conversation, in about half of the states in the U.S., the pandemic is actually accelerating rapidly, especially in the Sun Belt. And it's accelerating more rapidly in states that lifted their safer at home and shelter-in-place orders earlier than others. And I know Houston and Los Angeles are seeing unprecedented numbers of new cases, and Texas Children's Hospital is admitting adult patients with COVID-19 because the adult serving hospitals of the Texas Medical Center, which by the way is the largest medical center in our country, are overwhelmed with COVID-19 cases. So what can we do as citizens? Our toolbox for fighting COVID-19 is small, and it contains relatively blunt instruments. And those include hand washing, respiratory hygiene, face coverings, social distancing or protecting your 6-foot personal space bubble, and sanitization of common touch surfaces. And I would encourage people to continue to wear face coverings or masks when they interact with people from outside their household. Clearly, masks work to stop the spread. The data in favor of wearing face coverings are overwhelming and irrefutable. Face coverings in public should not be a political issue or a challenge to personal liberty. Wearing a face covering is a matter of common courtesy and responsible citizenship. And what it means is my mask protects you and your mask protects me.
Where do you think some of the biggest fallacies with regards to how we're kind of taking in all of this deluge of information? I know on my personal Facebook page, I've been like making that my one thing that I do is really try to encourage people to seek out the highest and best sources for information and things along that line.
Yes, I agree. And again, I talked about pseudoscience and self-proclaimed experts that have managed, because of the politicization of COVID-19, to find platforms for them to really spread misinformation. And in some cases, I believe that it's intentional and potentially politically motivated. In others, these are well-meaning, intelligent people that want to find some way to understand and control what's going on in a situation which is difficult for all of us to control. So your instincts to seek out the highest and best sources, maybe the most skeptical individuals who make a living out of being critical about information, and they know how to poke holes in new studies, is the right one. The Centers for Disease Control, World Health Organization, Wisconsin Department of Health Services, your local health department websites, local medical schools. Those would all be reliable, neutral sources of the best information.
But what do you track or kind of pay attention to how a lot of these rumors kind of take, on a life? And do you have any examples of some of that?
I would say the Plandemic infomercial that was widely disseminated on social media would probably be the best example of pseudoscience at best, that had, I think, 8 million views before it was taken down from some of the social media platforms. And, very intelligent people seeking good information found there to be some logic in it, even though much of the information that was shared was simply not true. What
is that? I mean, when you're looking at how some of that information plays out into human behavior? What damage does it do to how you are really trying to kind of get the right information? What does that mean as far as getting pushback from sources and things along that line?
Well, first of all, it's fine. It's hard to get an audience when you have hundreds and thousands of very loud voices out there trying to spread information that may not be well curated. So just getting an audience that is willing to listen to the best information is somewhat challenging. And, I think, again, because the wearing of face coverings has become a political issue, there are many people that just don't want to hear something that goes against what they've heard from people around them on their social networks, from the news media that they follow. And the issue of wearing face coverings, it's the most important thing that we can do to stop the spread of this disease. We don't have a vaccine. We don't have highly effective treatments. We really just need that to try to protect other people around us. And what's really problematical about COVID-19 and what makes it difficult for people to really grasp the importance of wearing the face coverings is that people can spread the disease when they have no symptoms or before they develop symptoms. In fact, there are some studies that show in the days leading up to the first symptoms, those are the days that would be the day that you're most contagious. So again, I think this infodemic is a real problem for us. And part of it is what's different now than even a few years ago. We have burgeoning social media channels that are easily accessible. I would say that many newspapers that used to have a science writer that understood how to critically read the literature in science, because of the strain and stress on the media industry, there are no more science writers, even in some of the largest newspapers in the country. And so you have people that are covering the stories that may not have the breadth and depth of experience that they should to be able to put things into context. Media want to generate clicks, so they sensationalize headlines and maybe oversimplify some difficult findings. So there are a lot of factors that are playing into the difficulty that people have in understanding what's good information and what isn't.
Yeah. So how are we doing in Wisconsin with like PPE and capacity?
Yeah, thank you. It's a great question. I think nationally our supply chain for personal protective equipment still is disrupted. One of the things we learned is that we were relying on a just-in-time supply chain that depended on other countries. I think over the last few months, especially in Wisconsin, many of our manufacturing companies have tried to address that issue by switching their manufacturing capacity to produce personal protective equipment. So our supply chain remains fragile and disrupted, but it's better than it was a few months ago. Now, in terms of our hospitals, we have enough personal protective equipment that hospitals can feel relatively safe trying to resume some semblance of normal operations and restoring the ability to care for people without COVID-19. But this still remains a very significant concern, and I think the concern is heightened here in southeastern Wisconsin, where we have the highest burden of COVID-19, and our hospitals tend to be running a little bit fuller, closer to capacity, both in terms of regular beds and ICU beds than in the rest of the state. So the most critical shortages right now are in hospital gowns, paper face masks, goggles, and N95 masks. And if you're interested in tracking the daily supply, the Wisconsin Hospital Association website updates their 133 hospitals and the critical shortages of personal protective equipment every day. And you can even focus that down into the HERC regions. There are 7 of those in southeastern Wisconsin. It's HERC 7.
I've used that quite a bit, but I wanted to kind of get the broader context of how we were responding to it. So, if I could, Denise, maybe I should have mentioned a couple things. We know a whole lot more now about what you can do to preserve and reuse personal
protective equipment than we knew back in March. We're doing things that we've never done before. Typically, PPE was a one-use item that would be disposed of, and now there are very valid protocols for sterilizing N95 masks and other forms of PPE to allow responsible reuse. And I think that's also helped us to protect the supply chain.
So can we also talk a little bit about the long-term effects of getting COVID and what that experience is like? Because I've seen that it's not like you're in the hospital for a few weeks, and depending on some of the comorbidities that you may have. Is that accurate?
Maybe I'll just start by saying we only have 6 months of experience with COVID-19 and really 4 here in the United States. I know it seems like it's been with us forever, but we're still learning a lot about the disease. And one thing that is one fact that's emerging is that many people that have had COVID-19, even people that had mild symptoms, are having difficulty shaking the disease off. They may have fatigue that lasts for months. There may be pulmonary issues that persist for months and possibly could persist for their lifetime. People that have suffered from blood clots from COVID-19 may have difficulty with circulation to their limbs and may have an inability to resume normal function. And again, we need to remember we're only 4 months into this year in most of the United States, so we don't have a large body of evidence about what happens to people in the long run.
Yeah. The other thing I also wondered, I know that I've done some pieces around the effective rate of the PCR testing and how it's the swab, how this person is swabbed, and whether or not they're shedding or not, and things along that line. But I've also gotten some questions about the efficacy of an antibody test versus a PCR test.
Mm-hmm. Okay, well, there are a lot of concepts in there,
okay.
So please forgive me if I try to touch on all of them. But
okay.
Let me first say that the PCR test done by a high-volume reference lab is very sensitive and very specific. The two challenges with the PCR test, that's the test that we use for diagnosis right now. It requires an experienced person to do the collection because you have to place the swab very deep into the nasopharynx, and it's uncomfortable. And so there may be collections that are inadequate because the person that tried to collect the specimen weren't vigorous enough about getting a good swab. The second problem with the PCR test is that there may be people who have a very low burden of virus, and so it's difficult to detect early on, but then within the next day or so, they become symptomatic. So those are the two problems with antibody testing. What I would say is the utility of antibody tests for individuals to make decisions, it's pretty low. And what I would say is a lot of the kits, we call them lateral flow assays. These would be kits where you just take a drop of blood or a pinprick and read it like a pregnancy test, have virtually no utility. I do not recommend using them. The better antibody tests where you have to draw a tube of blood and then run it at a high-volume reference lab, especially if they're run on reputable national platforms like the Abbott platform or the Roche platform or the Quest platforms, are really pretty good. And what they can tell you is that the number of people in a population that have been exposed to COVID-19 and developed antibodies. So I would say that the antibody test is more useful for public health departments to understand the burden of COVID-19 in their community over time, but it has no utility for making the diagnosis of an active infection, and it has very little utility in being able to tell somebody that they're immune from getting a second infection from COVID-19. There have been some studies published in the last week that suggest that if you get COVID-19 antibodies, that they may start to diminish after a couple of months. and we still don't know for certain whether having antibodies gives you significant protection from a second infection. So for all those reasons, I do not recommend antibody testing as a routine component of individual care.
But what about like PCR testing, like on a frequent basis?
There's no good answer to that. I think people are very eager to do at least one PCR test before they bring their people back to work. This is a problem that we're grappling with here at MCW. We have over 6,000 employees, and we sent about 4,000 of them to work from home back in March. And as we slowly reopen our education, research, and clinical enterprises, we want to bring people back. So we'd like to test our employees at least once. But we're really going to be relying on symptom screening and exposure before we would do secondary testing on people. And we still have a capacity issue here in Wisconsin. We have, I think, I have to look at the numbers, but I think we have over 60 laboratories now that are certified to do tests, and our capacity is up to about 17,800 per day. But we're not using that full capacity. We've been averaging about 11 to 12,000 tests per day. But that only leaves us 5,000 or 6,000 tests for people going back to work, students going back to school. So there's not a large margin for us there. So, I think we're going to probably, for the foreseeable future, rely somewhat on contact tracing and on symptom screening.
Yeah, that's another one of my questions that I was going to ask you of how are we doing with contact tracing? As these communities really start some of them are having to do a lot more of it than others, and even within some of the rural areas, because Racine County is kind of divided into the country and the city. So I just was curious about that too.
Let me first of all say our public health departments in Wisconsin are doing a fantastic job under very difficult circumstances of doing contact tracing, and that's been helped a lot by the increased availability of the PCR test and our better understanding of the populations that are at risk. But we do have some challenges, and I think one of the big challenges is that even within some counties, there's not just one public health department, and trying to coordinate the contact tracing and reporting across a county that has multiple public health departments and across every county in the state is really a difficult task. I think the Department of Health Services and the local health departments have done a fabulous job. My concern, though, is if we have a surge here, or if we have a significant outbreak that isn't contained within a workplace or a congregate living setting, that the capacity of our public health officials to be able to do contact tracing might be exceeded. And, I would look to Houston and Los Angeles, which have very sophisticated public health infrastructures and a lot of resources, and they're overwhelmed right now. And they were really in a good position just 2 weeks ago.
Also, I just had a thought as far as when voting was happening, we all thought, there's going to be a spike after voting. And when the protests around safer at home started happening, everybody thought, we're going to have another spike. And then there were the protests around a lot of the George Floyd case. And so are you seeing any data around these protests and these very public things that we're attending that are influencing how the infection rate?
Let me say that we've always been concerned about in-person voting, protests, and holidays at times where people would naturally want to congregate with their extended families and maybe relax social distancing. To the best of my knowledge, there is no good evidence to strongly support that there were surges that were caused by any of those events. That's a really difficult thing to do, and I know in some states they're not even asking people with new COVID-19 diagnoses whether they participated in protests. So it's going to be a challenging public health issue for us. But one thing that we know for sure, as states have begun to relax their safer at home orders and they've begun to reopen, especially the states in the Sun Belt that reopened earlier than some other states, we are seeing increasing numbers of COVID-19 cases. We didn't see that surge happen in the first week to 2 weeks when people were really looking for it. I think in part because people were afraid to go back and resume normal activities. As people have become less afraid to mix and mingle, maybe to not wear a face covering or to relax their social distancing, I think we're starting to see surges really related to individual behavior more than these large events that we talked about with the protests and voting in person.
Yeah, that's what I was wondering because, there was, last week I covered.
Denise,
go ahead. Go ahead.
Denise, I'm sorry to interrupt. I just want to be respectful of time. If you could maybe ask one more question, that would be good.
Sure.
Okay.
So, Dr. Raymond, tell me, are there any other concerns at this point that are on your radar in how we move through COVID-19?
Thank you. Thanks for the question. First of all, I did want to clarify one thing I said earlier. There are 68 current laboratories currently doing testing, and the capacity is 17,668. So what are my concerns? We were doing better than most other states. And the stretch between June 2nd and June 18th, there was a clear downward turn in the trajectory of COVID-19 pandemic here in Wisconsin. That's exemplified by the reproductive number, which is a measure of the contagiousness of the disease. We were under 1.0 for 16 consecutive days. And typically, if you're making progress in a pandemic, you want that number to be less than 1. So a number of 1.0 means that one person infected with COVID-19 on average passes the disease along to one other person. So if it's less than 1, then you have a deceleration of the pandemic. For the last 5 days, the reproductive number has been over 1, and it seems to be climbing. So that tells us that the progress that we were making has stopped. We're sort of stuttering right now, and we may be going in the wrong direction. And again, we were doing better than other states, but the trend in the other states was for them to have a downward trajectory of their pandemic and then to start to creep up and then rapidly accelerate. And so I do have a concern that if people believe that we're back to normal, and just because the safer home order was overturned, the Racine Forward order was overturned, I think 5 days ago, that they're in the clear. People need to understand that this virus is still with us. It moves. It is spread from one person to another. The more that we mingle with each other, the more people that we mingle with, the closer we are to other people, and the less people that wear face coverings, the more this pandemic is going to spread.
Okay, that sounds like a note that we should end on then. I want to thank you so much for the time that you spent.
Hey, listen, I like Racine Eye. I think you're doing a really, really good work down there. So I want to make sure that you know that.
Thanks. All right, well, thank you so much. I appreciate it.
All right, thank you as well.
All right.